Hello, my name is Dominique Seo, and I'm the 2024-2025 Health Equity Fellow at the Center for Innovation and Value Research. Through this presentation, I'll be introducing the Generalized Risk-Adjusted Cost-Effectiveness, or GRACE framework, and I'll also be discussing the feasibility of applying GRACE to our current cost-effectiveness model for Major Depressive Disorder, or MDD. For this, and to make sure that we're all on the same page, I'll start with a quick introduction to MDD, cost-effectiveness analysis, then move into a discussion of the GRACE framework, and finish with a discussion on the challenges of applying the GRACE framework using our MDD model. Major Depressive Disorder, or MDD, is one of the most common mental health disorders. It impacts more than 280 million people globally, making it one of the leading causes of disease burden. It's characterized by persistent sadness, loss of interest, and other symptoms that can significantly impact daily life. Treatment for MDD is usually multimodal and includes a combination of psychotherapy and/or medication. And before we dig deeper, we're going to have a little crash course in health economics to set the stage. In economics, we have a concept called utility, which is just a fancy way of saying the satisfaction or happiness that someone gets from consuming a good or service. For example, if you buy a bowl of ice cream and it boosts your mood, that happiness gained is utility. In healthcare, we use this idea a bit differently. Here, utility reflects the value or preference people place on different health states, from perfect health to very poor health or even death. These utility values are estimated different ways using survey tools like the EQ5D or the Visual Analog Scale, or VAS. Cost effectiveness analysis, or CEA, takes this one step further, and it's a method that we use to compare the costs and outcomes of different health interventions. These outcomes could be things like life years gained, heart attacks avoided, or deaths prevented. A common outcome is the quality adjusted life year, or QALY, which combines how long someone lives in a health state with their utility in that health state over a certain period of time. And when we compare two treatments, we can understand the extra cost and the extra benefit of a given treatment and calculate what we call an incremental cost effectiveness ratio, or ICER. This value tells us how much more we're willing to pay for each additional quality adjusted life year or effect measure gained. Here I have an example of a traditional cost effectiveness analysis. In this case, I've pulled from the open source MDD model that's previously been published by the center. And in this model, we're comparing the treatment costs for people with MDD who use SSRIs versus psychotherapy and SSRIs alone. For this, we subtract the cost of SSRI treatment alone from the cost of SSRIs plus therapy. And similarly, we can calculate the difference in the number of quality adjusted life years between the two treatment arms. And when we do this, we find that the cost of SSRIs plus therapy is about $25,000 higher than SSRIs alone. And we also see that people gain about 0.03 QALYs with the addition of psychotherapy. After we do this, we find that it produces an ICER of about $759,000 per QALY. And while CEA is a useful tool, it's not perfect, and there are a few important limitations to keep in mind. First, there's the idea that a QALY is a QALY is a QALY, meaning that all qualities are treated equally, regardless of who gets them, what condition they have, or how severe their illness is. For example, mild depression has been assigned utility values of around 0.9, and similarly, individuals with lower limb paralysis have reported utility values also around 0.9. So with the current setup, treatments improving either condition would lead similar QALY gains and would appear to have similar increases in quality of life. But intuitively, we may feel that helping someone with a more serious condition or a condition for which there is no other treatment should have higher priority or value. Second, cost effectiveness analysis assumes that people are risk neutral over health. This figure is a bit complicated, but on the x-axis, we have different quality of life values, and on the y-axis, we have different utility values. And what I really want to demonstrate through this figure is that individuals have different risk preferences. So on the left, we have a utility curve or function for a risk-averse person who would prefer treatment with a guaranteed moderate improvement over one that might provide a great improvement or no improvement at all. In the middle, we see a risk-neutral curve for a person who would be indifferent between certain and uncertain health outcomes with the same expected health gains and would make a decision then regarding treatment initiation based on other factors like cost or convenience. And on the right, we have a risk-loving person who prefers uncertain health outcomes or certain ones with the same expected value of health. So think, for example, a person who has severe depression who's already cycled through 3 or 4 lines of treatment with no relief. They may be more likely to try a risky treatment to gain a moderate amount of benefit. CEA typically assumes that people are in the middle or are risk neutral, but in real life, especially in conditions like MDD, some patients may prefer a treatment that offers even a small chance of full remission, and this is exactly the kind of value that traditional cost-effectiveness analysis and where a framework like GRACE can help to bring in patient-centered perspectives. Thirdly, traditional CEA typically leaves out other important value elements like disease severity, so trying to answer questions like, are we helping the sickest patients first? The value of hope, so trying to understand if patients have access to breakthrough therapies or last chance treatments, and equity, so thinking about if we're reducing disparities in who gets care. And this is where the GRACE methodology comes in. What GRACE does is compare both the costs and benefits of treatment and also adjust for patient risk levels. Unlike traditional models, GRACE takes into account the baseline health or how sick someone is before treatment and accounts for different utility functions, which allows us to model different risk preferences. This helps us to model more real-world situations and potentially makes our comparisons fairer and helps decision makers see whether or not a new treatment is worth the cost for the target population. There are several reasons why MDD could be a good candidate to apply the GRACE framework. To start, MDD does not impact all people in the same way. For instance, some have mild symptoms while others face severe treatment-resistant depression, which results in a wide range of risk preferences. These preferences can also be impacted by comorbid conditions like anxiety. For instance, researchers have found that people with MDD and co-occurring anxiety may show heightened risk aversion due to increased loss of sensitivity and a tendency to avoid outcomes with potential negative consequences, while other studies suggest that MDD patients may exhibit increased risk-seeking behavior due to impaired decision-making abilities and a tendency to focus on potential gains rather than potential losses. Also, not everyone responds to treatment in the same way. While some people may respond to the first line of therapies, others may cycle through multiple medications. So the value of treatment really depends on the patient's starting point. For instance, for someone with severe depression, even a modest improvement might be very meaningful. By adjusting for risk preferences, GRACE can help to support fairer and more accurate evaluations of treatment value in major depressive disorder. So if we're actually going to implement GRACE, I've identified some areas where there are currently data gaps. And so if we were going to implement GRACE today for MDD, there are several key data gaps that we don't currently have. And these data could be sourced from the literature or collected prospectively. When applying GRACE, utility estimates need to be on the visual analog scale. So in order to implement GRACE, we would need MDD and US-specific utility scores using the visual analog scale, or we would need to map them from another measure. Also, there's currently limited data on how people with MDD weigh risk and benefits of treatment, so more MDD-specific information would be useful to determine which utility function would best fit the preferences of this community. And with this, we do have utility functions for the entire population, but MDD-specific functions could help to model how treatment outcomes translate into value specifically for the MDD population. And while it's not strictly necessary, things like work productivity or caregiving burden and other non-health outcomes would be valuable for MDD. Lastly, it would be helpful to have more data on how people's quality of life changes throughout their MDD journey. Given these data gaps, there are some assumptions that need to be made to implement GRACE today. First, we would have to assume that MDD patients have consistent and quantifiable risk preferences when moving between health states. For instance, when moving between moderate to severe depression. We also would need to assume that the published utility functions that have been estimated using a national sample are applicable to the MDD population, and we would have to decide on whether or not non-health impact should be captured in the model. And some challenges to consider when applying the GRACE framework is that historically, many studies report utilities using a measure like the EQ5D or SF60, not the visual analog scale, and mapping is imperfect and can introduce error. Additionally, there's no current studies, to my knowledge, that directly estimate risk aversion or the utility functions in MDD patients, so we would have to rely on national estimates, although these may represent the mental health population. Additionally, I want to note that MDD health states fluctuate, and current models often assume fixed utilities per health state. And lastly, one of the major hurdles in applying GRACE will be stakeholder understanding and trust. GRACE adds complexity and unfamiliar math, like nonlinear utilities and diminishing returns, which may reduce uptake among payers or clinicians and may add a hurdle into patient participation in this research. And so from the limitations in traditional cost effectiveness that I discussed earlier, GRACE addresses these first by recognizing that not all QALYs are equal, and it's able to account for who receives the QALYs and considers the condition being treated and severity of illness at baseline. Also, GRACE incorporates risk preferences, moving beyond the risk-neutral assumption in traditional CEA. This reflects more real-world patient and societal risk attitudes. And lastly, GRACE goes beyond just costs and QALYs and is able to capture additional factors that are important to patients and decision makers, like equity, innovation, and caregiver burden. So, based on what I have discovered, I think that GRACE can be applied now as a proof of concept, and though there are assumptions that would need to be made, all models have assumptions, and by accounting for patient risk preferences when considering new treatments, GRACE could be a valuable addition to the value story for a new treatment for MDD and beyond. Thank you, and if you have any questions or comments, please do not hesitate to reach out to me via email.